Hello, I'm Justin Shepard, Vice President of ErgoScience. We're going to talk today about return to work screens and how you can maximize your profit by providing value for others. The basis of this presentation is that if you've already been trained in a good functional capacity evaluation system, you can use that training to generate revenue in other avenues, not just by performing FCEs. Let's talk about return to work decisions. Let's imagine you're treating a work comp patient. He's plateaued with his treatment and it's time for the proverbial return to work decision. The case manager is asking for your opinion to share with the physician. So how do you know if he's ready to go back to work? Send him back too soon and he gets injured, and now you've got a potential lawsuit waiting to happen for you and the MD. Hold him out too long and you and the MD get a reputation for being too soft on work comp patients, and then your referrals start to dry up. So how do you know? If you've been trained in a good FCE system, this allows you to perform a return to work test, or what we call a mini FCE, as part of your discharge evaluation, comparing the results of the return to work test to the patient's job demands. It will clearly and objectively show whether the patient is ready to return to work. You can also include a consistency of effort test in the mix, providing some extra support for your feelings about the patient's level of effort, good or bad. One of the big benefits about performing return to work testing with your work comp patients is that it's great for their confidence about going back to work. Anyone who's done a lot of work comp knows that when you're sending someone back to work who's had a serious injury, there can be some real fear avoidance behavior. Not that the person doesn't really want to go back to work, but they're afraid they could get re-injured. A lot of these people have very undesirable work conditions, very physically demanding tasks, and if they've had previous injuries, there's a higher likelihood that they have some inhibitions about returning. So let's say that you've been treating a patient with a lumbar strain for several weeks. He's telling you that his job is really heavy. Now, his pain is almost gone, and he has nearly full range of motion, and his core strength is improved, and he wants to go back to work. He feels like he's ready to go back, but is he really ready? When you perform that return to work test, the patient gets a fair shake by providing objective data for this decision with an objective, defensible return to work screen. The patient knows that they can perform the job. So if you allow that patient to perform tasks that represent the 3 or 4 most physically challenging aspects of the job in a 30-minute screen as part of your discharge evaluation, then they know, they have confidence that they can go back to work and do the hardest things required of them there. For the patients who don't get any type of return to work screen, then they're guessing that they can do the things that are required of them when they go back. And if they've had a serious injury, that leaves them in a little bit of limbo. And what about from the employer's point of view? Most employers really do want to do what's best for their employee who's been injured on the job, but they also have to be profitable. Both points require a worker to return to work at the appropriate time. Return too early and you risk re-injury and an angry, unproductive employee. If you take them out too long, it hurts productivity and it affects worker morale. So the employer wants the employee to be happy, they want to be profitable, and they want to avoid lawsuits. If you've been trained in a good FCE system, it helps you to reassure employers that the worker is really ready to go back to work. It gives them confidence that critical job tasks can not only be performed, but can be performed safely. It will also show that the critical task can be sustained for an 8-hour day or a 40-hour work week, not just for a few minutes while they're there inside of your clinic. And it provides defensible data for the return to work decision. Let's discuss a couple of return to work scenarios. In this first one, Mr. Smith injured his shoulder lifting a heavy piece of machinery at work. After 12 visits of physical therapy, his Occal physician receives the following information from the PT's discharge report. Right shoulder has 168 degrees of shoulder flexion, 50 degrees of extension, 78 degrees of external rotation, 70 degrees of internal rotation, and 155 degrees of abduction. He has 5 out of 5 strength in all planes, and his reflexes and sensation are within normal limits. Armed with that information, if you're the Occ Health doc, do you return Mr. Smith to work? And if so, at full duty or light duty, do there need to be any accommodations? Let's just assume that upon seeing 5 out of 5 strength and good range of motion, the MD sends him back to work. But after struggling through 2 8-hour days of full duty, Mr. Smith informs his supervisor that his shoulder is killing him. He can't lift anything overhead. He gets a sharp pain each time he carries equipment with his right hand, and he wants to return to the doctor. As a physical therapist, how does this affect your relationship with that doctor, the case manager, the adjuster, the employer, and the patient? Let's look at it a little bit differently in scenario 2. So, same patient, Mr. Smith injured his shoulder. He's had 12 visits of physical therapy. He's getting ready to go back to that Occ Health physician for his discharge report. And he has this information from the physical therapist. So his range of motion is good, 168 degrees of flexion, 50 degrees of extension, good external rotation and internal rotation, decent abduction at 155 degrees. He has 5 out of 5 strength in all planes. Reflexes and sensation are within normal limits. And based on the job description provided by the employer, the following tasks were tested by the physical therapist. A floor to waist lift, waist to eye level lift, 2-handed carrying, 1-handed carrying, working with arms overhead and standing, and climbing a ladder were performed as part of a return to work test. Because you had a job description, you knew what the person had to do to go back to work. And from his performance on the return to work test, you could see that he was able to lift 40 pounds from floor to waist. But while the job demand is for 25 pounds from waist to eye level, Mr. Smith was only able to lift 15 pounds. He was able to carry 50 pounds like he needed to for his job description, but when it came to one-handed carrying, he was only able to carry 15 pounds versus the 25 pounds that he needed to for his job. He was able to work with his arms overhead occasionally, but according to his job description, he needs to do that frequently on the job site. And climbing a ladder, he didn't have any problem with. Again, as the Occ Health physician, armed with this information, you recommend that Mr. Smith participate in 2 weeks of structured work conditioning. After the 2 weeks, you, as the physical therapist, retest him with that same return to work test and send these results back to the Occ Health physician. You can see now that after 2 weeks of work conditioning, Mr. Smith has the physical capabilities to return to work. He's able to do the waist to eye level lift at 25 pounds. He's able to one-handed carry of 25 pounds like he needed to. And he's able to work with arms overhead frequently instead of occasionally like it was previously. As PTs, if we don't give the Occ Health physicians adequate information, they're guessing. And they usually will have neither the time nor the equipment to get this information on their own. So by performing a brief return to work screen as part of your discharge evaluation and comparing the results to the patient's job demands, you'll be able to clearly and objectively show whether the patient is really ready to return to work. To create a proper return to work screen, there's a few steps that you have to take. Number one, you need either a job description or the ability to interview the employer or supervisor, or you could interview a patient or employee as the sole source of job demands info, though we don't recommend that. You have to figure out how you develop the test, and then you would need to decide what is the timing of test administration. A good job description is critical for selecting the task that you'll use in developing the screen. If you can't get a good job description, or the job description is incomplete or vague on the details of the physical demands, try to get more detailed information through a job demands interview with the supervisor at the job or from the employee or the patient. If you don't have a great job description, this is a great way to get on site with employers. As a work comp specialist, you can offer your services to the safety director or the OC health nurse on site to help them with the job demands analysis. Now, a lot of times we're given job descriptions that are extremely vague. Employee has to lift, push, pull, stand, walk, carry. Armed with that information, that really doesn't help you to create a return to work screen at all. We need objective data. So this is a great opportunity for you to volunteer your services, get on site, develop a better relationship with the employer, and it gives you the ability to perform a much better return to work test. If there is no job description and you don't have the bandwidth to get on site and put together your own information, you can get the information from an employer or a supervisor, somebody who's intimately familiar with the job. And you would typically get their contact information through the case manager or the adjuster. And when you're doing this, typically you would ask that employer about the 3 to 4 most difficult tasks or most physically challenging tasks of the job that you're looking at, especially considering the body part involved in the primary injury or illness. You'll want to ask about the heaviest weights handled in lifting, carrying, pushing, and pulling. Ask if the job has significant requirements that do not involve weight handling. So that would be ladder climbing, crawling, kneeling, bending. And if they have these tasks, you want to find out what % of the day do they spend performing that task. Like I said before, if you can't get a job description and you can't get on site, and you can't find an employer or a supervisor to interview to get the information, then you'll have to get the information from the employee or the patient, but really do this only as a last resort, because the information that you get there is going to be less valid, it's less defensible, and it's really not in your best interest or in the best interest of that patient. If you do have to go that route, at least try to confirm the information from the patient with the employer at a later time. If you really want to develop a legally defensible return to work test, you need to start with an objective, evidence-based FCE system with a validated scoring protocol so it will stand up in court. You must be able to accurately predict the patient's ability to perform an 8-hour workday or a 40-hour work week, and you must be able to objectively assign Department of Labor frequencies and physical demand levels. When you're choosing which tasks to include on your test, you'll want to consider testing manual materials handling. So again, you're lifting, carrying, pushing, or pulling. And then you'll choose other physically demanding tasks from the position tolerance and mobility tasks, such as working with arms overhead and standing, or work bent over stooping, squatting, kneeling, climbing a ladder, climbing stairs, crawling, repetitive squatting, anything that is going to be physically challenging. Again, and we're wanting to look specifically at the injured body part as well. What are the things that are going to affect it the most going back to work? When we're looking at passing criteria for the return to work test, remember that the testing of weight handling should never exceed the job demands. So don't just test lift or carry to the patient's max effort unless you can't get any good job information. So if you don't have a job description and you don't have an idea of what this person has to do, at that point you could test them to their max abilities, but if you have that information, then you would only test them to the level of their job. And to make tasks more job specific, you may want to adjust the height of your lifts, like your shelving, put that at the height that they have to do it at the job site. The same thing for your distances for carrying, the height of above shoulder reach, if that's included in the specific job information. To decide when you're going to administer the return to work test, obviously you would do it as their outpatient treatment is ending. You don't necessarily want to do it on their very last visit, just in case they miss that visit. So I typically would plan mine on their second to last visit. Ideally, at that point, they're most of the way better. I don't have any serious fears about them getting re-injured performing the test. When you do these, you can use the 97750 CPT code, and that's billed as a functional test. You need to ensure that you know the date of the patient's appointment for his or her return to work decision so you can schedule the return to work test in advance. This ensures the physician will have the return to work report for the appointment. It really doesn't help the physician much if maybe they're going back to see, the employee is going back to see the doctor before your final scheduled visit, and you're planning on doing your return to work test after that visit. It's not going to do the physician much good, and it doesn't help him with that return to work decision. In the case that you have someone who doesn't pass all the aspects of the return to work test, like in our scenario previously, and you should recommend work conditioning for those patients. It's a great source of revenue in a physical therapy clinic. It's not difficult to perform, and it's what's best for that patient. But if you plan on doing this, communication with the case manager, insurance adjuster, and physician is imperative. This isn't just something that you can decide he's going to do work conditioning and start seeing him for that service. You would recommend work conditioning for all those who fail to meet all the job requirements as tested, providing an estimate of the duration of the work conditioning. So if it was just one task that they weren't able to pass and they weren't very far away from it, maybe this person only needs 1 week of work conditioning. If there were significant gaps between the employee's tested abilities and the job demands, it's likely that they're going to need more time, 2 or 3 weeks of work conditioning. Your work conditioning sessions will typically include some elements of strengthening, cardiovascular work, stretching, and sometimes balance if that's a critical aspect of the patient's job. Encourage return to work on modified or temporary duty while they come to work conditioning with you at your clinic if available. The last thing we want is for somebody to sit at home while they're waiting to go back to full duty. That's not good for the patient, it's not good for the employer. Thank you for going through this presentation with me. If you have questions about return to work testing, about FCEs, about work conditioning, I would love to hear from you. My contact information is here. Please feel free to reach out. Again, thank you very much.